everyone. We're just about to commence the next session in 1 minute. So if we could ask people who are outside to please come in, and we will Thank you, everyone. Welcome for our second session of the APLC symposium today. We will still have some people walking in, but I think we'll start our session now. I'm going to hand over to my co-chair, Dr. Ng Soo Chin, and who will introduce our very esteemed speaker, Professor Mark Litso.
Hello, everybody. It's our honor to have Professor Mark Litso with us. He's Professor of Medicine in the Division of Hematology at Mayo Clinic. Professor Litso served as the Director of the Blood and Marrow Transplant Program at Mayo Clinic for 17 years and remains an active member of the BMT program. He chairs the Leukemia Committee of ECOG Equine and has been involved in the development of large Phase 2 and Phase 3 clinical trials for the past 20 years. He has also been a long-standing and active member of the Acute Leukemia Committee for the Center of International Blood and Marrow Transplant Research. These efforts have contributed to the improvement and outcome for patients with acute leukemia and chronic myeloid leukemia, and to improve survival of patients after blood and marrow transplantation. Without further ado, I will call upon Professor Mark Litso.
Thank you very much for having me. It's a great honor to be here. I was wondering if one of the criteria to be a speaker here, your first name had to start with Mark. And Dr. Levis will be a hard act to follow, but I will do my best. So my topic today is integration of immunotherapy into frontline ALL treatment. These are my disclosures. My objectives during our time together is to discuss the results of the E1910 clinical trial, and then review other studies utilizing blinatumomab and inotuzumab in B-cell precursor ALL in the adult setting, and then advise on potential best approaches to integrate immunotherapy into frontline treatment. So I'll be focusing initially on blinatumomab, which I think most, if not all of you, are familiar with, a bispecific T-cell engaging molecule. Up to the time of the E1910 trial, it was approved for relapse and refractory ALL in the United States, and also for MRD positive B-ALL in adults and children. So the E1910 trial, I had the good fortune to lead. I presented initially at a late-breaking session at ASH in 2022, and then perhaps many of you know that it was published in the New England Journal at the end of July of this year. And this was the overall schema of the trial. Now, we had, in the ECOG Leukemia Committee, collaborated with the Medical Research Council in Great Britain and done a trial called E2993. And that was asking a transplant question, but used a chemotherapy backbone typical of adult ALL. And we incorporated that regimen into the E1910 trial. We made some modifications to, I'll say, make it a little bit more pediatric-like, but it followed that general schema. So patients had an initial 2 months of induction therapy. If they achieved a conventional complete remission, then they were able to stay on study. If they did not achieve a conventional complete remission, they went off treatment. They then got an intensification with high-dose methotrexate for CNS prophylaxis. And then at that point, their MRD status was again studied, and if they were MRD negative, they were randomized either to go to the right and get 4 cycles of consolidation chemotherapy and then go on to maintenance therapy, or go off to an allogeneic transplant at the investigator's discretion. Or the experimental arm was to get 2 cycles of blinatumomab, the 28-day continuous infusion with a 2-week break in between, and 3 of the same consolidation that they got in the control arm, then another cycle of blinatumomab, another cycle of chemotherapy, another cycle of blinatumomab, and then could go off to maintenance therapy. And these patients could also go off to an allogeneic transplant. We hope that that would be done after the blinatumomab. You can see the stratification factors on the lower left. And this was a United States intergroup study. We had participation from our colleagues in Canada and Israel, and it was a one-to-one randomization. The primary objective was to compare the overall survival in the MRD negative patients who received blinatumomab plus chemotherapy to chemotherapy alone. And you can see our statistical assumptions. We felt we needed a minimum of 190 patients to be projected to be MRD negative, and this would result in an accrual goal of 488 based on our previous studies. You can see the power calculations that we incorporated into the study. So with this study, which actually began back in 2013, we assessed MRD by flow cytometry in our translational research laboratory centrally by Dr. Elizabeth Paeta. And this was based on a MRD assay that is utilized by the Children's Oncology Group in the United States. So patients between the ages of 30 and 70 were eligible. The median age was right in the middle, 51. And we chose this age range because we didn't want to compete with a trial that was in development by the Alliance Cooperative Group that was going to be addressing treatment in adolescents and young adults. So our CR/CRI rate was 81%. Most of these were complete remissions. The FDA, when it approved blinatumomab initially, only allowed it to be given for a 24 or 48-hour infusion, but we were able to get these longer infusions done, which made it more feasible and user-friendly, I will say, for the centers. That enhanced our accrual. So the study activated in December of 2013 and completed accrual in just under 6 years. 286 patients were randomized or assigned, and I'll explain that to the step 3 to the time of randomization. 224 that were MRD negative and 62 that were MRD positive. I'm not showing this, but the baseline characteristics between the two arms were well balanced. We initially planned to randomize the MRD positive patients, but the FDA approved blinatumomab for MRD positive disease during the course of the study, and we were already seeing that investigators were not wanting their patients to be randomized to chemotherapy alone. And so we changed the protocol and assigned the MRD positive patients to the blinatumomab plus chemotherapy arm. So as I mentioned, our complete remission rate was 81%. What happened to the patients between on study enrollment and the randomization? Well, we lost 19 patients, or 4%, to induction toxicity, and I list the causes there. Of the 395 patients that achieved a remission, 109 did not get to the randomization, and this was for a variety of reasons that, again, I list here. Some of them died from toxicity, some relapsed quickly for adverse events. Some patients and their physicians felt that they shouldn't continue on the study, and they withdrew them. So the 488 that we initially enrolled, 59% made it to the randomization or assignment step. And this was the primary endpoint, which was overall survival in the MRD negative patients. And at the time of this analysis, there was 43 months of follow-up, and you can see the advantage for the addition of blinatumomab. At 3 years, the overall survival was 85% versus 68%. And this is from the time of randomization. And you can see that the p-value was highly significant at 0.003. Now, interestingly, among the 224 MRD negative patients, 22 in each arm, we didn't plan that, but 22 in each arm underwent a non-study allogeneic transplant. And 80% of the patients received 2 cycles or more of the blinatumomab. A little over 50% received all 4 cycles. You can see at the bottom the deaths. There were many more deaths from relapse in the chemotherapy arm, as you can see, compared to the blinatumomab plus chemotherapy arm. We saw similar results for relapse-free survival with a significant p-value here as well. These were the results in the MRD positive patients. So we had 40 that got blinatumomab plus chemotherapy, some that were randomized, some that were assigned. This was an intent to treat analysis, so there were some patients that were assigned to chemotherapy who actually ended up, the physician took them off study and gave them blinatumomab, but because it was an intention to treat, we had to consider them within the chemotherapy group. So you can see there's a difference in the curves, but it didn't reach statistical significance, I think, because of the smaller numbers. We then did some post hoc analyses. We used age 55 as a cutoff because the patients over 55 did not get asparaginase during induction and they got a shorter course of steroids. So we used that to do this age analysis. And patients between 30 and 55 had a highly significant benefit from blinatumomab plus chemotherapy. You can see there's hardly any relapses compared to the chemotherapy arm, and again, a highly significant p-value. We did not see as much of a benefit in the patients of 55 or older. The curves appear to perhaps be separating, but at this point, there's not a significant difference in those older patients between blin plus chemo and chemotherapy. Now, Bijal Shah did an interesting sort of an analysis that he had sent me, looking at the breakdown of molecular changes within the different age groups by decade. So 30 to 39, 40 to 49, 50 to 59, and 60 to 70. And what you can see is the blue column is a pH-like patients, and you can see that actually it went down a little bit as patients got older. But the red and the green are, the red is a complex or hypodiploid patients, and the green is TP53 mutated patients. So you can see, not surprisingly, that there were a higher number of these patients with adverse risk cytogenetics and TP53 in the older patients compared to the younger patients. This might have accounted somewhat for some of the differences. This is a forest plot looking at the overall survival. I already showed you some of the age changes. The second group there is the pH-like, variable-like, and you can see there didn't seem to be a strong benefit for the pH-like patients. We did do a combined molecular risk analysis, which I will show you in more detail in a moment. Also show you some transplant data. We did allow rituximab. It was an elective use by investigators for patients that were CD20. This is the transplant data, just looking at the patients that got transplanted on study. We got blinatumomab versus chemotherapy. The top solid curve is the blinatumomab group, so they appear to be doing perhaps a little better, but you can see the p-values are not significant. So the chemotherapy patients didn't do really significantly worse. And then we sent samples on all of the patients to Charles Mulligan's lab at St. Jude's Hospital in Tennessee. I think you're aware that he has done very sophisticated analyses looking at molecular subtypes of ALL, and these were the different groups that we looked at. And so we grouped the patients into favorable risk, which I list here, the high hyperdiploid, the DUX4, and then an unfavorable group, the typical ones you think of, the KMT2A or MLL rearranged, the low hypodiploid, near haploid, BCR-ABL-like, et cetera, and then an intermediate group. And then we looked at outcomes on the study based on these molecular groups, and this is the favorable group. And interestingly, you're not seeing any relapses in these favorable group of patients who got blin plus chemo versus chemotherapy. For reasons unclear to me, we didn't see as much benefit for the intermediate patients. But we did see a benefit for blin plus chemo in the unfavorable risk patients, which was very encouraging to see. The unfavorable risk patients, I've always felt in my practice that regardless of their MRD status, they should be considered for a transplant given their higher risk of relapse. We tried to look at this And this is, again, a subset analysis, which you have to take with multiple grains of salt, I'll say. So of the 50 patients with unfavorable risk status who were randomized to chemotherapy plus Blinn, we looked at then whether they got transplanted or not, and now we're getting down to very small numbers. But in 14 patients who underwent transplant versus those who did not, we actually saw a better survival. Just go by the percentages in the patients who didn't get transplanted. So I've changed my thinking about unfavorable risk patients and thinking that if they get blinatumomab plus chemotherapy, they're MRD negative and then remain MRD negative, that perhaps they don't need to be transplanted and can be followed closely post-transplant. Now, the toxicity profile between the two arms was pretty similar, but one notable difference was we saw 23% of patients that had grade 3 to 5 treatment-related neurologic or psychiatric adverse events versus 5% in the chemotherapy group. That 23% seems high, but we included things like headache as a neuropsychiatric event. Even though these patients are getting blinatumomab in remission, there is still some risk of these neuropsychiatric events. So concluding from this study, this is the first study to show in a randomized fashion a benefit for blinatumomab in MRD negative, BCR-ABL negative B lineage ALL. The biggest benefit appeared to be in younger patients. We saw benefit in favorable and unfavorable risk patients. We also looked, and I didn't show this data, at the patients that achieved true MRD negativity versus those that we called MRD negative because they were at less than 10 to the minus 4, but we still saw some positivity. Blinatumomab benefited both of those groups. So on the basis of this study largely and some other trials, the FDA approved blinatumomab for a third indication now, and they made it fairly broad, just saying for consolidation therapy of CD19 positive Philadelphia chromosome negative B cell precursor ALL. And this was, approval came through in June of this year. And you can see on the lower left, there's further follow-up, which was reported in the package insert of 82.4% for blinatumomab at 5 years versus 62% for the chemotherapy only. I'd like to turn now and talk about some other studies, mostly phase 2 trials that have looked at the incorporation of blinatumomab into upfront treatment. And this was a study that was presented at ASH last year by the Gemima group in Italy, where they treated a group of adult patients, 149 patients, and gave induction chemotherapy, as you can see, cycle 1, cycle 2, high dose intensification, somewhat similar to E1910. Then gave blinatumomab, and their primary endpoint was to look at MRD at time point 2 before the first blinatumomab and at time point 3 after the second blinatumomab. Then they gave a subsequent cycle of blinatumomab later, and patients could go off to transplant if they had high-risk disease or were MRD positive. So this was the breakdown of some of their patients. They had about 20% of the patients over the age of 55. This was the risk group, standard risk, high risk, and very high risk. And then these were some of the molecular findings that they had. The KMT2A was at just under 10%, and they had 28% that were BCR-ABL-like or PH-like. And then you can see some of their cytogenetic profile. So this is some of their data. What I'm showing green here was their primary endpoint. They went from 70% MRD negative at time point 2 after the chemotherapy up to 93% after the cycle of blinatumomab. And you can see on the lower left that the MRD at time point 3, if they broke it down by the age groups, at here, the results were similar, 89, 95, and 100%. However, if you looked at standard risk, high risk, very high risk, there was a drop off in the very high risk patients, not as many patients responding. You looked at how patients did at the time point 2 the ones that were MRD negative did better than the ones that were MRD positive, but blinatumomab seemed to overcome some of that, as you can see on the right. And then this was their pH-like patients. You can see 74% that were non-pH-like for overall survival versus 54% for the pH-like, and similar results with the disease-free survival. And MRD negativity, however, was still high in the pH-like, as you can see in the green box. Now, the SWOG group, led by Anjali Advani, did a small study in 29 patients. These were patients over the age of 65. This was published a couple of years ago in the JCO, where they used single-agent blinatumomab as therapy in these patients. And you can see the schema on the right. They got a cycle of blinatumomab, and then depending on their response, they went on and got more blinatumomab. So this was patients, the median age was 75 years. You can see some of the other characteristics. With standard risk 55% and poor risk 34% by cytogenetics. They did not have any deaths during the first 28 days of treatment. They had only one CRS and one neurotoxicity. They achieved a complete remission rate of 66%, and 13 of these 19 responders had MRD data available, and 12 of them became MRD negative. One patient went to transplant. You can see the survival curves. There's no plateau, but they look more encouraging than one would see in this population with chemotherapy. And then this was a trial that was run by Hovan and was presented at EHA. And you can see that they gave a pre-phase of blinatumomab with steroids, which I'll go into more detail about, and then 2 additional cycles of blinatumomab later on interspersed with chemotherapy. This was a phase 2 trial again, and they compared it to their historical controls. And so these were patients between the ages of 18 and 70. They set a pediatric-inspired protocol. The initial pre-phase was only 14 days of blinatumomab from day +5, and then 10 days of steroids, and the 2 subsequent cycles of blinatumomab. So this was their characteristics of their patients. Median age was 53. See the age breakdown. Most of them had at least one high-risk feature. 70 patients received the first full course of blinatumomab. They had some CRS and ICANS. And 15 patients had to discontinue their protocol for the reasons shown. So after just 14 days of blinatumomab and the steroids, they had a 58% early CR, and 46% of these 58% were MRD negative. This increased after the first blina consolidation to 95% CR rate, and 91% of those were MRD negative. You can see the estimated 4-year event-free survival. They're not seeing dramatic differences in survival compared to their control group, but 86% versus 74% for the younger patients, 71% versus 51% for the older patients. The event-free survival. And I apologize for these survival curves. I took them from the abstract, so they're a little bit blurred when I tried to blow them up. But the red and blue curves are for the patients under 40. The red is their current study versus their historical, and then the kind of brownish and green are the over 40 patients. So physicians often ask me, well, where do I incorporate blinatumomab into my chemotherapy regimen? Now, the C10403 regimen is a regimen that's used frequently in the United States. It was based on a Children's Oncology Group study, and Wendy Stock with the Alliance led this phase 2 trial and showing excellent results. So the reason I have the X through the extended remission is that that's no longer used, but I've just shown here where one could consider incorporating blinatumomab. And the Alliance trial, they actually, at the red arrow, that's where they incorporated 2 cycles of blinatumomab based on the results of E1910. So I want to just talk briefly in the remaining minutes about the other immunoconjugate that's available widely, inotuzumab ozogamicin. This is a CD22 antibody that's linked to cytotoxic agent calicheamycin, sort of similar to Mylotarg, which had a CD33 antibody linked to calicheamycin. And the MD Anderson group sort of led the way in incorporating INA into upfront therapy. And this is their hyper-CVAD regimen where they added both blinatumomab and inotuzumab. You can see they gave 4 cycles of chemotherapy, numbers 1 through 4. The bluish arrows are the inotuzumab. And then instead of the last 4 cycles of chemotherapy, they've added the blinatumomab, and that's the red boxes, 1, 2, 3, 4. And then incorporated some additional blinatumomab during maintenance. And I'll cut to the chase here in terms of these results, which were presented at ASH last year. You can see in the bottom left the excellent overall and relapse-free survival. These are the curves for the red is with blina and the blue is with blina plus inotuzumab. Here's the overall survival, which is looking very encouraging with short follow-up. And this is blue is their historical controls with hyper-CVAD and a CD20 antibody ofatumumab. And they're also thinking that if these patients do well, they may not need to be considered for transplant. These are the high-risk patients in red versus blue is greater than 1 high-risk feature. The red is no high-risk features. And this is looking at transplant, suggesting that if these patients achieve a good response, they may not. And then you're, I think, familiar with their mini CVD regimen. They've also added inotuzumab and blinatumomab to this regimen. And you can see some of the characteristics of the patients here. These are patients over the age of 60. Some of their features, and then how they broke down studies. And you can see here the MRD responses look high. Complete remission duration is good, but the overall survival is up. And they had quite a number of deaths in CR from a variety of reasons. Some of these patients actually got AML. Many of them had infections. Here, a few with VOD. So I think the jury is still out on this regimen and the ability to use it, particularly in this older subset of patients. And inotuzumab, I think, has to be used cautiously. The Alliance trial that I've been alluding to in younger adults actually had to be stopped because they added inotuzumab to their C10403 regimen, but had a number of later infectious deaths. Had to modify that regimen. Then I want to mention the study that was just recently published by the German group, the Initial 1 trial, where they gave inotuzumab in induction with dexamethasone 3 cycles. And they went on to give more conventional chemotherapy and maintenance therapy. These were for patients over the age of 55. They enrolled 45 patients. They had a very high CR rate of 100%. Persisted after the 3rd cycle of induction. And they had very few deaths in induction. These were high-risk patients, but you can see the survival on the lower left there looks very encouraging overall in these high-risk patients. And these are their survival curves. Event-free overall survival, their relapse rate, and relatively low death rate and first remission. And the last study I want to mention is, I think, a unique and encouraging study that's going to be published soon. This was led by the Alliance group. Matt Wiedewelt led this study. And this was for older adults using a chemotherapy-free regimen, combining inotuzumab and blinatumomab. So the patients received an initial induction with inotuzumab, and then depending on their response, they had some cytoreduction, they continued inotuzumab. If they didn't, then they went on to get blinatumomab, and these patients were consolidated with blinatumomab, and response assessments were done. Patients did get chemotherapy for CNS prophylaxis. So this was a smaller study, 33 patients, median age of 71. 8 of the patients had had a prior malignancy. 6 of those 8 had had prior multiple myeloma. We're seeing ALL as a secondary complication of myeloma. You can see the induction and the maintenance treatment. There's the intrathecal therapy, 8 treatments. CR rate was 85% after inotuzumab. The cumulative CR up to 97%. The 1-year event-free and overall survival are 75 and 84% respectively. You can see the relapses. There were 2 deaths in CR, 9 deaths overall. And the survival curves are on the lower right. Overall survival, not clear that it's plateauing, but certainly these results are much better than one would see with chemotherapy. So what have we learned from all of this? Well, I think the importance of immunotherapy and improving outcomes. Saw this in E1910 with blinatumomab. And it appears that blinatumomab can be combined safely either following chemotherapy or interspersed with chemotherapy, as we did in E1910. And up to 4 cycles can be given. I have been asked, how many cycles do you need to give? You need to give all 4 cycles. We tried to look at that and actually presented some data at a meeting, but we're suspect about that data because there's so many confounding factors. Recall that the transplant patients only got 2 cycles of blinatumomab. So I can't definitively say that 2 is as good as 4. So right now I've been recommending that if possible, try to give all 4. Now in E1910, we had a lot of drop-off of patients, as I showed you, from the time they went on study until they got to the randomization. And I think the message that we're getting there is to incorporate immunotherapy earlier in the course of treatment, either potentially during induction or replace induction, or at least get it going sooner to ease some of the toxicity from chemotherapy and help try to maintain responses. And I think the ideal combination to use these agents is yet to be determined. I haven't spoken at all in this session about CAR T-cell therapy. That potentially move closer to the upfront setting. I think that's a consideration. All these therapies are getting quite expensive, and so that also needs to be taken into account. Could we reach a point where we could potentially abandon chemotherapy? I think that's potentially a possibility, but particularly in older patients, I think I would be reluctant to do that yet in a younger patient. So with that, I'll acknowledge my colleagues in the ECOG Akron leukemia group, especially Dr. Jacob Rowe and Marty Tallman, who mentored me and were instrumental in my success in my career. Our collaboration with National Cancer Research Institute, the former MRC in Great Britain, my colleagues at SWOG and the Alliance. So thank you very much.
Thank you very much, Professor Litzow. If you please join us on the table, and we'll invite our other panelist members to the table now. Melissa Ooi from Singapore, Dr. Yesu Peng from China, and Dr. Wasitep Limvo Ratapinak from Thailand. Thank you. You'll also see we're going to try something a bit different this year as well, in that we're going to try some audience participation. So we'll see some challenges, but see how we go from that point of view. On the subsequent screens, we've actually pre-prepared some questions that we're going to show to the panel members as well as the audience, and to get your responses. So let's see how this works. First of all, should we proceed with the questions now? Polling questions? Or do I need to show it? Oh, there you go. So the E1910 is obviously going to be a practice-changing study, and we just need those polling questions to appear up on the screen. I'll let the technical people run. Good. So our first question for audience members, is that the Menti code? The Menti code on your tables that you'll be able to vote on. The question 1, is blinatumomab available for use at your institution? With the 4 answers you can select there. I'll give that another, yes, another few seconds. All right. Let's go to question 2. Oh, here we go. So the answers to the Menti code are there. Oh, good Lord. It's real time. So our answers that healthcare or institutional government support for institution support in the Asia Pacific is not that high. We're seeing about a third of healthcare institutions subsidies for blinatumomab and 2/3 of patients requiring private access for funds. Okay, ooh. Let's wait another second. I think 35, we've got quite stability. Let's move on to the next question. Question 2. Want to select? Here we go. Thank you, technical people. Question 2. What would you recommend if your patient does not achieve MRD negativity following induction? You can see the answers there, and voting opens now. Continue current standard of care. If transplant eligible, work up for stem cell transplant. 3 is intensification of therapy, including addition of asparaginase. And 4 is use of immunotherapy. Menti code and votes in. Yes. Interesting responses. So 1/10 of respondents continue current standard of care, about fighting between transplant eligible, consider transplant workup. Intensive asparaginase is not very popular, and about 4 of 10 patients, 2/5, consider the use of immunotherapy. Ooh, what's going up to stem cell transplant? Okay, that's reasonably stable. Let's move on to our next question. Yep. Question 3. How would you define high-risk ALL in your daily clinical practice? The answer's there by MRD as a response assessment, 2 by cytogenetic features, a diagnostic assessment, by MRD and cytogenetic features, and 4 by conventional parameters, such as clinical parameters at presentation. And we didn't add age in there, but that is something that to consider. Yes. So 3/4 MRD and cytogenetics and 25% by clinical parameters. Interestingly, 4% only by cytogenetic features. And we'll go to our question 4 now. Thank you. What would you recommend if your patient does achieve MRD negativity following induction therapy? Interesting question now. Continue current standard of care protocol and continue monitoring MRD by whichever method. 2, addition of blinatumomab in consolidation, a very important consideration given the E1910 results. 3, continue addition of asparaginase, for example. And 4, consider donor search and transplant workup. Votes in now. Here we go. Practice changing indeed. We have stability. And moving on to our final question. It's question 5. And maybe we'll use the age cutoff of 55 years rather than 50 years. What would you recommend if your patient is older than the age of 55 and achieves MRD negativity following induction? Menti votes in now for the responses. continue standard of care therapy and monitor MRD, if not for allo transplant and CR1. 2, commence a donor search and workup to consider transplant and CR1. 3, commence donor search and workup to consider CR1 in transplant eligible patients if they are defined as high-risk disease, presumably in addition to the age, such as PH-like or KMT2A rearranged. And 4, would you consider addition of blinatumomab in consolidation? Votes in. So we're reaching stability. So third, really thinking about stem cell transplant for high-risk disease, and certainly people are now considering the use of blinatumomab in consolidation if available in the older group. Thank you very much. I think that did work. We also have online Professor Kwok Yok Lam, who is joining us as well. Thank you. And perhaps I'll throw now to the panelists, members, and to Professor Litzo to discuss some of perhaps the results of the E1910 and interestingly, the responses to our survey just before. So I'll open to the panelists and now. Perhaps Professor Lam, would you like to open the discussion as you're dialing in, and we'd like to hear your thoughts.
Well, thank you very much. I really do not have any additional points except to ask the question, because blinatumomab is an expensive medication, and we have not really had a lot of evidence to say that in the MRD negative situation, we have to give it for such a long time. Now, do we have any idea on whether this can be abbreviated, for instance? I understand that in the MRD positive situation, you might want to give more of the medication, but is there any evidence that in an MRD negative situation, we can actually abbreviate the treatment so as to cut the cost of treatment?
Well, I alluded to that at the end of my discussion that we tried to look at whether giving less cycles, we tried to look at whether the patients that got less cycles of blinatumomab benefited equally as well as the patients that got 4 cycles. And that analysis is problematic because there's so many variables involved. And so I don't think I can say with confidence that 2 cycles is as good as 4 cycles at this point. And right now, I think getting some blinatumomab in is still better than getting none. So I think if you are only able to give 2 cycles, I will still recommend doing that. If you're able to give the 4, I would lean toward doing that. In kind of the talks that I've given over the past year or so, people have also asked me, do we need to give 4 weeks of blinatumomab? And I think that that's also an open question that I don't have an answer to, but certainly you saw the HOVON data where they gave 2 cycles gave 2 weeks of therapy in their pre-phase and saw a fairly high response rate. So I think that could be a possibility as well, but ideally it would be best to study that and see whether a shorter duration was as beneficial. So I think that's the best I can say in answering that important question.
I certainly agree with you, and I think in the MRD negative situation, we ought to be doing more work to define whether we actually need that much medication for these patients, because after all, it's a very expensive medication.
The other point I just want to add is I don't know when this data will be available, but we saved samples from the patients, obviously, at the different MRD time points, and we are planning to go ahead. We won't have it for every patient, but to do NGS MRD testing using the clonoSEQ assay from an adaptive company to look and see what the results were, especially in the patients that were totally MRD negative by the flow assay, and then to see how the results correlate with the blinatumomab, just chemotherapy. So that's to follow. I hope we may have some of those results next year at some point.
Right, thank you very much. Maybe we can hear from other panelists.
I would just like to ask, of course, chemo-free immunotherapy is attractive on all counts, but how much of CNS protection we have? We still need to resort to conventional chemo to provide the CNS protection part. Am I right?
Well, I don't know. I think it's certainly a concern. I think there isn't as much data with chemo-free regimens in pH-negative ALL. The MD Anderson group has followed up on the Italian data, tumumab in pH ALL, and they did see. I think they were giving. I think they're up to 15, either 12 or 15. I don't remember. When they were giving, I think, 8 intrathecal treatments, they saw an increased CNS relapse. So I think I don't know that you need systemic chemotherapy to control the CNS, but I think you definitely need a significant number of intrathecal therapies to control the CNS. I think so. That's a very important point.
Would I ask any questions from the other panelists? Invite some questions.
Thank you very much for your talk. So I'd like to ask you about the older patient population. So I think you alluded to in part of your talk that if they're MRD negative, you may not want to consider allo transplant in first CR for the based on the 1910 data. But for the older patients who maybe got less chemo, even if they become MRD negative, would that still hold true, or would you consider transplant in those people?
Well, I think it's an open question, but I think that if they and the reason I'm pausing is we didn't see as much of a benefit for blinatumomab in the older patients, and then now you're asking a good question of you have an older patient who's high risk by their molecular genetics and cytogenetics. Should you transplant that patient? And I don't know the precise answer to that. I think it's going to depend on also their comorbidities and what their transplant risk is, and if you have a reasonable donor and so on. So I think that situation has to be more individualized. I think I'd have a little bit more assurance that if they did get blinatumomab and are MRD negative, that you might be able to get by without a transplant. But I'm afraid I can't answer that precisely.
May I just follow up that question in terms of transplant decision point? With the E1910 trial, the flow cytometry was used as an MRD stratification. But in terms of transplant decision, what MRD testing and sensitivity would you think about using for making that decision?
Well, I think we have the NGS testing now, and I think I would utilize that and go by that. If a patient achieves MRD negativity by NGS, by the clonoSEQ assay, then I think you can consider avoiding transplant in that patient. I think if they remain positive at almost any level, I would think about transplanting them, either after some attempt to get them to MRD negativity, or you could take them directly to transplant, even if they're MRD positive, and still get some benefit. I think we face always that problem, both in AML and ALL, is how much do you I'm going to, pardon my French, but beat up on a patient with treatment to try to get them MRD negative before you take them to transplant. But I think if they're MRD negative by your best assay, I don't think they necessarily need to be transplanted.
Dr. Peng?
I think the burning question for the transplanter is for MRD negative but unfavorable genetic characteristic, does the patient still need a transplant if we're using a blinatumomab as a consolidation and get MRD negativity and the patient is young, fit? But based on your data, although the case number is very small, but it seems the patient underwent the allogeneic stem cell transplant seems to have a relatively poor survival outcome. So for your daily practice, if a patient young, fit, and MRD negative using a blinatumomab as maintenance, but they have poor, unfavorable genetic characteristic, will you still recommend stem cell transplant or just keep preservation?
Well, I think my feeling now is that that I would not transplant them in first remission if they are MRD negative and get blinatumomab and then are followed closely and stay MRD negative. I think that would be my inclination. Again, it has to be a discussion with the patient, and I'll take all the other factors into account. But I think based on the E1910 data, I've really changed my thinking about that because I always used to recommend transplant to those patients, but now I am not as inclined to.
Another issue is if you look at the GMEMA study, the patient with a pH like ALL still doing a little bit worse compared to the pH not pH like ALL. So they use only 2 cycles of blinatumomab during consolidation. So I don't know, is it if the patient had poor characteristic, you would recommend more cycles of blinatumomab? But for negative, if the patient do not pH like, maybe 2 cycle consolidation, the data quite good. So currently in my institute for patients with MRD negative and do not have this characteristic, maybe I will just, I want 2 patients, I give the patient only 2 cycles of blinatumomab consolidation. But what do you thought?
Well, I think for a younger patient with unfavorable genetics, I would try to give the 4 cycles. I think I would want to maximize the non-transplant therapy to the extent that I can to try to minimize as much as possible the risk of relapse. So that would be, if I made the decision not to transplant them, then I would definitely feel more strongly about giving them the 4 cycles.
Perhaps before throwing to our next panelist, if I follow up on that question, noting that you're going to plan to do the clonoSEQ assays at different time points, do you think the study is powered enough in terms of the different genetic subtypes to be able to make it inference about that question, the duration, the number of cycles, and whether further cycles may be of benefit, knowing that also the TP53 mutations were also detected in quite a significant number of the older cohort?
Yeah, I think it's going to be a challenge because we're not going to be able to do. We don't have adequate samples on every patient that was randomized to do the clonoSEQ assay. So now if we have a smaller number there, and then you're looking at subsets, it could be challenging to see differences there. We'll have to see.
We wait with interest. And Dr. Limora Pitak.
Thank you, Dr. Liso, for your excellent talk. So my question would be, the E1910, they allowed the transplant after 2 cycles of linear consolidation. But I think there are previous studies saying maybe 4 cycles before transplant is even better than that. What do you think about?
I think my short answer is I don't know. I don't know the answer to that for sure. I mean, I think it's still, if you're planning to transplant the patient, I think it's still reasonable to do it after 2 cycles. If you're planning not to transplant the patient, then I would try to give 4.
We have a question from the audience, Prof. Go.
Hi, Kong, you're looking good. Miss you here. Yao Ti here. Okay, Kong is not listening.
Yes, I am here.
Okay, the question is actually, I just wonder your clonoSEQ. Yeah, we know that as far as we know, it's not available in Asia yet. So maybe we can go around the table to ask who's available. And I don't know what Australia has, but I know as far as we know, it's only in Japan. But my question is not regarding that. It's regarding CAR T. So we know that CAR T, probably not for this audience, but for our China colleagues, maybe we can ask them. They have quite a lot of CAR Ts, and where does the availability of CAR T fit into your transplant algorithm? Let's say you have a CAR T that's available, and you have a not so good patients like Melissa's case and so forth. Are you guys trying to consolidate the CAR Ts in cases where there's no transplant options and all that? How does that change your transplant algorithm? And maybe we can also get opinion from our China colleagues because they have quite a lot of CAR Ts.
That's an excellent question. I think that CAR T is certainly has been shown to be beneficial in MRD positive patients. So I think that could definitely be an alternative to consider, especially if someone got blinatumomab and say remained MRD positive. So I think CAR T cell therapy would definitely be worthwhile considering. Now, the other question out there is then does that patient need to have a transplant after the CAR T cell therapy if they're only MRD positive? And I think that's an unanswered question. I would give serious consideration to transplant on those patients, but I don't know that it's absolutely necessary. Now, doing CAR T cell therapy in patients that are MRD negative, that's another, leap forward. And I think that's something worth exploring. I know that one of our Chinese colleagues are looking at doing induction therapy and then giving CAR T. I was just you were just explaining that to me this morning.
Maybe we can hand the floor to Jian.
Yeah, please.
It's just due to in all countries some different situation. That's because blinatumomab not reimbursement in our country. That means if we use 0 cycles in our practice, may be very expensive. So that's why we're seeking for different approach in our country. That's why we use CAR T in frontline therapy after one induction therapy, 2 consolidation, and we put CD19 CAR in frontline. So we're to try 30 patients now. Looking at the NGS data for RGH sequencing, it looks very bad. It looks very good. Before CAR T, maybe it's NGS maybe reach the -10 to the -4. After CAR T reached the -6. So there are 2 log reduction for MRD. So after that, we go to the maintenance therapy. That's all. Yeah. Not commercial CAR T. It's just for the trial academic CAR T.
I think that's going to be very interesting to see the results of that trial. I think that's going to be very exciting. I think ultimately, how we incorporate these immunotherapies is still, an open question about how best to sequence them, and also looking at availability and expense, and these are all significant issues that need to be addressed as well.
Thank you. Perhaps I'll go to some of.
Can I ask you? After your CAR T, do you consolidate with transplant? And if not, is it like do you use MRD to decide on that pathway, or do you just do CAR T and then you stop there?
According to the design of the protocol, if after CAR T therapy, the MRD or NGS not become better, we'll go through the transplant. If it could better, okay. No, just stop here. But according to our data available right now, all the patients respond quite well. So no patient go to the transplant at the moment.
Thank you. Anything else, Melissa, would you understand? Okay.
No, this is not, this is, so for us, we don't have a trial, it's just more ad hoc, but for the patients who are on a IR protocol, we actually, for the high-risk ones or the ones who fail TP, like their MRD time points, we pull them out and we actually do CAR T on them. And then the difficult question is whether these patients do need a transplant to follow up after that. And we have done transplant in those who have, let's say, still persistent MRD positivity, or they have very high risk features. But that's always the question. And because it's not a trial, it's difficult to extrapolate the data for everybody. So it'd be interesting to see your trial when it's published.
I guess there's some reworking of the risk stratification, knowing from the pediatric data driving down MRD their outcomes, change, I guess, your schema in making that decision for that question. Driving down, so you now have data to suggest that monitoring, incorporating Blina into pH negative patients, there are patients who can then avoid transplant. But we've been using blinatumomab, let's say, in the MRD positive setting. Your thoughts now that that arm of the E1910 trial was closed early, your thoughts about the benefit of blinatumomab and how to use blinatumomab in that setting, in the MRD positive setting.
So you're saying if a patient has gotten blinatumomab as part of their initial therapy and then they become MRD positive, or?
One if they're both scenarios, MRD positive pre-blinatumomab and MRD positive post-blinatumomab.
Well, MRD positive pre-blinatumomab, I would consider transplanting them. I would give them blinatumomab, try to get them to MRD negativity, but I think I would still take that patient to transplant. If they become MRD positive after blinatumomab, then I think that's the ideal setting for CAR T cell therapy. Now, the responses with CAR T cell therapy are not as good in patients who've received blinatumomab compared to patients that have not received blinatumomab, but still the response rates are high, and it still would be, I think, the best treatment to think about in that setting. Now, inotuzumab has been used in the MRD setting also, and much more limited studies, but has shown some benefit. One needs to take into account the risk of sinusoidal obstruction syndrome, or VOD, if you're going to take them to transplant after that. So that needs to be thought about. But I think CAR T, if you're able to do it prior to after blinatumomab MRD positive and use CAR T and then take them to transplant, I think that's very reasonable.
Perhaps I could then call back to the potential controversial responses to the last panel question that we had, question 5. The significant proportion of respondents were thinking about incorporating blinatumomab in patients over the age of 55 if they achieved MRD negative response, and your thoughts about that.
Yeah. That's difficult. I guess I'm quite biased. I mean, I would still consider giving a patient over 55 blinatumomab if it's available and they can get coverage for it, but I can't definitively say that it's benefited them. What the right answer there is, I don't know. I hope perhaps with further follow-up we'll see a difference, the curve splitting more. But at this point, I can't sit here and definitively say that you must give a patient over 55 blinatumomab if they achieve MRD negativity with chemotherapy.
For adult patients, which is more about the AYA population, your thoughts about genomic risk stratification, I guess, in terms of the implementation of Blin. The COG 1712 trial, they issued a statement about ETV6 RUNX1 good prognosis, the arm on that trial, where they still did not recommend introducing blinatumomab in the consolidation compared to the other standard risk and high risk groups. So do you think genomic stratification in an AYA population will still have a role in making those decision stratifications?
Well, I think it would. I don't think you can directly compare an AYA patient to a pediatric patient. So I think I would still, at this point, continue to use that sort of stratification. Charles Mulligan is actually doing further, more detailed analyses on the E1910 population, looking at whole genome sequencing, and so we'll see if that gives us any further information about those patients. So that'll be interesting to see as well.
Any other questions from the floor or from our panelists? That's been a really very, very interesting session. Again, it'll be a practice-changing study. It is a practice-changing study already. Fantastic for you to come and speak with us. Great illuminating discussion from the panelists as well as the audience. So I'll hand over to my co-chair to close the session.
Thanks again. Sorry.
Oh, it's Lisa.
No, it's actually just it's just curiosity. Since we have about 10 minutes, what are people using for Philadelphia positive BALL? Chemo-free, some sort of immunotherapy? I'm just curious because that's something that we struggle with.
Perhaps we should have a second question on the screen actually after this, but perhaps we'll throw to Professor Litzau for his thoughts about the approaches to pH positive ALL in 3 different age groups: the AYA, adult, and older.
Well, I think the chemo-free regimens that are looking encouraging. The follow-up is relatively short with the MD Anderson data. The D-ALBA trial, they just presented some longer-term data. That regimen did include some chemotherapy later on. I believe in Italy they're doing a randomized trial of the chemo-free versus chemotherapy, and we are in the United States. Actually, it's a study led by my ECOG group, but it's an intergroup trial, and we're doing hyper-CVAD plus ponatinib or dasatinib investigator choice versus blinatumomab plus ponatinib or dasatinib. And so I hope that we'll have more definitive information from that trial. I think in a younger patient, I would still be inclined to give chemotherapy and TKI. I think just a younger patient and the potential for cure, I think I would still be reluctant to change to a newer therapy. But I think in older patients, I'll jump to that group. I think using blinatumomab and a TKI is certainly reasonable. And I think the adult group in the middle, that's more challenging, and I think that has to be more individualized. One little plug I would make is there's been a couple interesting studies that have looked at the PH-ALL subgroup and kind of been able to divide them into groups that seem to be purely lymphoid, and then there's the group that has some myeloid characteristics and look sort of more like they might have they might be like a CML blast crisis. And I think in that population, to jump to blinatumomab plus TKI, you run the risk that you could have emergence of a myeloid clone that could progress in those patients. And in my discussions with the MD Anderson folks, they tend to give those, try to distinguish that and be sure to give those patients chemotherapy. So I think that's an important detail to be aware of.
Sorry for the same question. Because based on the trial, the TKI was continued only for 5 years. So for the pH positive ALL outside the clinical trial, and patient tolerate very well to the TKI, will you stop the TKI at 5 years or try to continue just what we treat the CML?
I don't think there's any good answer to that. The patients that I have treated now, most of these patients I've transplanted, and I've continued a TKI after their transplant. I've even done up to 5 years in those patients. If you had a patient that you didn't transplant, how long to continue the TKI, I think, is an open question. I think the chances, if they're staying MRD negative, if the chance of them relapsing after 5 years, I think would be very low. So I think you could consider stopping, but I don't think we have an answer.
Actually, that's my question too, because long ago it was 2 years, then it moved to 5 years. I have patients now at 5 years, but I dare not stop. So, thanks for answering that question. But what about transplant in this Philadelphia group? We know that for the older patients, I think there's no-brainer. If it's MRD, you can skip the transplant. But for the younger group, do you still offer a transplant if they go in MRD negativity, or do you select? And where do you draw the line?
Well, there was a retrospective study that was published in Blood, multi-center study, that if they achieved a MRD negative remission by 3 months, that they did as well with or without a transplant. So I think if they achieve an MRD negative remission by 3 months, I would not consider transplanting.
For all groups?
I think so. Yeah, I think so. The other caveat, and I don't know if many of you may have seen the MD Anderson data and some other groups that, it depends on how you monitor MRD.
Correct.
And
so
pH
is it by
positive
BCR-ABL or by NGS or both? MD is actually both is best, but yeah.
Well, I think NGS is, I think the data is emerging that NGS is best. And that some patients, because some patients can be BCR-ABL, persistently BCR-ABL positive, but if they're, if they're negative by NGS, they do equally well as the ones that are negative. So I don't think you need to transplant those patients.
Show that if it's both NGS and the BCR-ABL, it's actually very, very good. But I suppose then if these NGS and negative, but BCR-ABL positive, would you continue? Would you do a transplant, or would you say?
No, I would, based on what I've seen currently, I would not do a transplant.
Okay.
If the NGS is negative, I would continue treatment, but this could be mature progenitors that are, expressing the BCR-ABL and not going to necessarily lead to progressive disease.
What about transplant role in the BCR-ABL negative, but additional mutation, resurface after monitoring? What do you think?
If they're developing additional mutations? Yeah. I'm not sure what I would do in that situation. I think it would depend on the scenario. I guess I would be inclined to think about, it would depend on the mutation pattern. I'm just trying to think about this as I'm speaking, what mutations were showing up. I mean, I would be very concerned about that patient, so I might consider transplanting them in that scenario. But I'm just trying to think of a scenario where that would come up, because why would you, if they're MRD negative, why would you be doing testing for additional genetic abnormalities?
Suppose it's from the NGS lymphoid, and you see, other things coming up, but the BCR-ABL was negative. Suppose. You're
talking about the BCR-ABL positive patients?
Oh yeah. In the BCR pH positive ALL, you treat them, and then with the NGS lymphoid, and the BCR-ABL became negative, but there are other mutations coming up.
Oh,
right.
That would be very concerning, I think.
Yeah, because I think
the new clone could be emerging. Yes. Yeah,
KMT2A or whatnot, right?
Yeah, I would be very concerned about that. Yeah.
Before closing, following that question, thoughts about translocations associated with mixed lineage acute leukemia with a B phenotype initially at presentation. Have you seen any transformations to a mild?
I'm sorry, this mixed phenotype at diagnosis?
Mixed phenotype at diagnosis, or mixed phenotype at diagnosis first, and secondary, if you've had relapses in myeloid phenotype, if there were KMT2A or BCR-ABL,
I've certainly seen that with KMT2A patients where they had they looked like ALL, a lymphoid, and we gave them blinatumomab, and they relapsed with a myeloid clone. That would definitely be. I think is that what you're getting at? Yeah. I think that's pretty well described now and a concern.
I think we're 1 minute away, so we are done for the day. We're closed for the second time. Thanks very much for the panelists, of course, our esteemed speaker, and thanks, Kwang. Yeah. And thanks for the attendees. Thank you.
Thank you very much, ladies and gentlemen, for your kind cooperation and your attention for this morning session. And after this, we are going to have a photo session. But beforehand, please let the organizer to manage to arrange the 2 front row seats for this session. So may I have your kind cooperation for taking your own belongings with you for the first 2 rows? Participants, thank you.